what does it mean for the individual to be intoxicated? Remember, alcohol is a downer. It's a substance abuse. Every substance abuse, the best way to figure out how to answer questions about them is to consider them whether they're upper or downer. A downer means their symptoms when you are intoxicated, you go down, your symptoms go down. Alcohol is very notorious in terms of things that it does to you. Sometimes your symptoms go up and down, and so people get confused. But when we say alcohol intoxication, it means uh, immediate effect of what we see, right? Immediate effect. So if you drink alcohol, immediate effect of what we see is what we mean by alcohol intoxication, right? It's just what we see. Therefore, what do you think? There's certain things, like I said, it's a downer. So you don't have to memorize the symptoms. I'm going to give you like straightforward, these are like quick information with the pathophysiology. So for the neuro aspect, neurological, yeah, it's going to go down. When things are going down, what is that? You look drowsy, right? Drowsiness. They're going to get confused, right? Their speech will be slurred. These are few of them. I'm not going to give you a bunch of them, but these are the things, their judgment is all like altered judgment, right? Because of the alcohol, they cannot make a good judgment. So because it's a downer, this is what happens to your neurological system. When it comes to the cardiovascular system, it's different. Even though it's a downer, you will see signs and symptoms of upper and lower and downer in intoxication. Intoxication means the patient drinking alcohol. So they may be hypotensive because of the dehydration associated with it, but they may have tachycardia. Okay, even though this is upper symptoms, they will be a tachycardic or they may have arrhythmia. This is where you have to be careful to make sure you understand alcohol problem. This is the only thing I want you to pay attention. This is, apart from that, most alcohol symptoms follow the same pattern. The respiratory is a downer. So you know that their respiratory status will decrease. So respiratory depression, right? And this can be life threatening. So these are NSAIDs may go down, right? Yeah, respiratory rate will go down. And then you'll be able to figure out what is going on with the individual. I've seen questions about metabolic symptoms. You have to know that alcohol is very notorious causing hypoglycemia. So anybody who is intoxicated come in, watch for that. They may be hypoglycemia because of diuresis. It impair gluconeogenesis. You can make glucose, impair liver formation of glucose. So this is also very interesting how alcohol can cause hypoglycemia in patients. So somebody come in, what do you do? Always think about, okay, and so what? What is the nurse going to do? Somebody come in with the intoxication, what do you have to do? Go through your ABC, right? You got to make sure his airway intact, his breathing, and the circulation is fine. Based on the signs and symptoms I've given you, hey, you got to be ready to intubate them because of their respiratory status will be impaired. What do you think? Number one thing you should worry about based on the ABC. What do you think? What do you think you should worry about? It's related to the A. So what do you think? It's related to A symptoms, and that is aspiration. So you have to worry that these people may aspirate on themselves. So that's another thing. That's why you got to go through the ABC and think about it. The other thing too is you have to worry about I call it co-injection of other drugs. You got to make sure they're not taking alcohol and benzos, so their side effect will be more prominent, maybe more prominent. And then worry about electrolyte abnormality. If you don't know this, people who are alcoholic, Their magnesium is like really low. So low magnesium. You have to, and their potassium is also low. So that's why they go into cardiac arrhythmia. This is the explanation, the pathophysiology. I'm a pathophysiology guy. I always like to explain to you why it's happening. Alcoholic go into arrhythmia and tachycardia because of this. Their magnesium is very low and their potassium is very low. So these are quick information regarding alcohol withdrawal symptoms. And this is what you see. But this is an intoxication effect. It's an intoxication. Your body mostly like withdrawal rather than intoxication. So watch for that. So what do you see in a withdrawal? Withdrawal symptoms is more dangerous. So the withdrawal symptoms is very dangerous. Problem with what? Substance abuse. Substance abuse, the medication, if you classify them as a downer and a upper, if you intoxicate, you go in the direction of the medication name, like alcohol. Since it's a downer, when you intoxicate, you go downer, you go down. When you withdraw, it will be opposite. You don't have it. So your symptoms will rather go up. So this is the key. We call it central nervous system hyperactivity. That means things start going what? Upper symptoms. They start looking like they are ramp up. The central nervous system is like way up. It get confused. It just want to go up. The timeline is very important. So 6 to 8 hours, that's when that was the last time you stop drinking, that's when you start withdrawal. If they drink every day. So the key concept is somebody who was admitted to the hospital, he drinks every day, and 8 hours later, is having signs and symptoms of withdrawal. They won't tell you it's tachycardic, his respiratory rate goes up, everything is going up. That's the key. So every time they give you a question, it says somebody was just admitted, all of a sudden, boom, those symptoms. He came in for something else and he's looking like he's having tachycardia, respiratory rate is going up, always worry about alcohol withdrawal symptoms. That was what the case is about. Um, if you don't do anything within like 12 to 24 hours, this is where they go to DT, right? I would say they go into seizures first. And then if you don't do, and they start having hallucination. And if you don't do anything within 48 hours, 72 hours, they go into DT. So you have to know a little bit of details relating to that. So what would that happen? I told you it's withdrawal, hyperactivity. Well, they become tachycardic, right? Their blood pressure goes up. Everything is going to up. They're going to start sweating, right? What do you think neurological symptoms, what are they going to show? It's still going to go up. Things will go up. They start showing signs and symptoms of things going up. And then that will be related to um, their anxiety. They will become anxious. They will be restless, right? And if you don't do anything, like I said, they start having tremors, they go into seizures. These are all classic signs and symptoms of alcohol withdrawal. And then they go into DT, that's severe complication. They start seeing hallucination. Remember, this hallucination is key. This is mostly tactile. There's no auditory as hallucination. Mostly it's either visual or tactile. They will say they're seeing things on the wall. They can see things, something crawling on their skin, right? That's what they will tell you. It's never about auditory. They don't hear anything, but this is what you have to start thinking about what you need to do. Of course, seizure precaution is key for this patient. You have to ensure seizure precaution. So if they take you to fundamentals, make sure they are on their side, you protecting them for everything. Yeah. There was something about this also. Nursing care. What do you do? CIWA. Who knows what is CIWA? CIWA Protocol. We always talk about it. CIWA Protocol. This is what usually sometimes your board will ask you. This is it's a form of clinical evaluation by the nurse. The nurse is supposed to do that, and it's called clinical institute, right? Withdrawal assessment. Withdrawal assessment. And then this is a 10-point system, right? It's a 10 system you're checking for. It's a bunch of them. I will make it easy for you. Look for nausea. That's what they look for. They look for tremor. All the signs and symptoms we talk about, they will be sweating. Third one, anxiety. So these all has points. Agitation. In case they ask you what are the components, and then tactile distribution, like I told you, they will be feeling something on their skin. Um, they will they will be like the visual changes, and then sometimes auditory, but mostly they don't hear things, right? They will have headache, and then uh, in addition to that, the last one basically they worry about what orientation, sensorium, basically that's their orientation. Remember, all this has 7 points. This from here to here, this is either 0 or 7. So if you have one of them, you're 7. If you don't have it, 0. Except this orientation is 0 to 4. And they can calculate how much total that you have. And then they usually treat it with benzos. So depending on your levels, we'll give you benzos. So from 0 to 9 is usually just mild problem. Then 10 to 20 is moderate, and then greater than 20 is severe form. And you titrate based on benzos. Remember, titrate based on the benzo level. But this is what they use to calculate the duration of what individual you have to do. There's certain few things you have to know as you go through the management. There's certain things you have to do. Like I said, you're going to treat this with benzos. So they get benzo. Benzo is for the acute problem. It's not to prevent them from having seizures. So lorazepam, they have to replace their electrolytes. I told you the magnesium is very low and potassium. And then you have to replace their thiamine. Thiamine is very important. If you don't do that, they go into Wernicke encephalopathy. So you have to pay attention. They have thiamine deficiency. And then close monitoring as possible and seizure precaution. These are little things you have to know when they give you alcohol questions. What kind of things you should watch for? This is the question they ask, okay? Alcohol screening. Somebody come in, how do you know this patient is a problem? We call it CAGE. Who knows what it is? CAGE questionnaire. You have to ask the patient if they feel like they want to cut down how much they're drinking, right? Are they annoyed by anybody? This is the question you have to ask them. If they say no, there's a problem, right? Do they feel guilty? That's G. And then this one, I call it like an eye-opening. Like you need to get it before you can get better. Every morning, if you don't get alcohol, you can't do anything. That's a problem. This is how you can screen the individual whether they have a problem. Cage, don't forget it. Easy way. They will ask you, have you felt the need to cut down on your drinking? Have people annoying you by criticizing you that you drink or guilty? Have you ever felt guilty about drinking? Or do you need in the morning when you wake up, do you need like something to kick you up? Like eye opener. If they send all of this, they don't feel like I want to cut down, I'm not annoyed, I don't feel guilty, and nobody I need an eye opener. Yeah, they are alcoholic. Of course, NCLEX without pharmacology is not a problem. It's not a good content. You have to have pharmacology associated. Remember, pharmacology is not something big. What is the name? Pharmacology. Ecology. That means you providing medication to fix the problem. Every time there's alcohol, there's a pharmacological aspect you should expect that they can ask you. And people forget about these medication. When somebody come in and you're having treatment, we got to help with the withdrawal symptoms. In the withdrawal symptoms, in order to prevent seizures, we give them the benzos, so lorazepam, right? These are to prevent seizures to help them with that. As much as possible, this is acute problem. Yeah, otherwise, they're going to seizures. All the hyper symptoms I talk about, you need to calm them down. And in order to calm them down, you need to decrease the central nervous system, depress it. Remember, benzos is a dana. So in order to prevent individual from having seizures, you put them on benzodiazepine to help with that. So alcohol acting like that is why we do that. Now, after that, there's some medication, Disulfiram. Remember, this is not for withdrawal, okay? This is not for withdrawal symptoms at all. After we let them go home, this is what I call it alcohol aversion, right? That means if you drink alcohol while you're on this medication, you're going to hate yourself. So this is to prevent you from drinking it because it gives you unpleasant feeling when you take any alcohol while you're taking this medication. So this deter you. It's a deterrent. It's not for craving. That's the difference. It's a deterrent medication. It's not for craving. Be careful when you see that. That's all from. It's different from what? Naltrexone, right? This is to reduce your craving. When you go to a rehab, you may get naltrexone in addition to disulfiram. Disulfiram, you take it so that when you see alcohol, you run away from it. If you drink alcohol, you get really, really sick. But when you take naltrexone, when you see alcohol, you don't crave for it. There is a difference between them. It gives you a rewarding effect. It looks like alcohol, but it doesn't give you the same buzz, so it decreases your craving. Watch for these medication that you may see in the case question pharmacology. Acamprosate is another alcohol medication that it helps you abstain by normalizing brain activity. So it's the same thing. It's acting like naltrexone. It just makes you, but it doesn't help with the craving. It just give you some feeling, right? So it help with abstinence uh, by stimulating the brain. So don't confuse them. I want you to know these four medication. Lorazepam benzos is for what? Is to prevent you from having seizures. Disulfiram is to give you the unfeeling sensation so that you stay away from alcohol. Naltrexone will reduce your craving, and acamprosate basically it's the same thing, help with abstinence related to the medication. So these are some of the things I want you guys to know so that when you see questions, you'll be able to answer it. Um, so the key thing you have to know is this is just a short form of way to recognize what are the things you're supposed to know. They're going to confuse you, right? They will bring benzos information in it, but you have to be able to look at it and say, oh, don't, this is not the problem. Remember, alcohol is not just a downer. It can also have electrolyte abnormality. It can cause dehydration. It can cause the whole system. It can affect your liver. You can have encephalopathy. We call it Wernicke encephalopathy. So if those information comes in, just prepare to be able to figure out what to do. So in brief, I mean, this is a short lecture to show you some of the things they may ask you. So, what if I give you a table like that? Okay, so these are alcohol and I'll post intoxication. This is intoxication. And this is a withdrawal symptoms. Withdrawal. So I put here tachycardia. Heart rate is up. It can be either intoxicated or withdrawal. But when a respiratory rate go down, it's a downer, so intoxication. And drowsiness, it look like symptoms are going down, right? So drowsiness. Tremor, it look like your symptoms is going up, right? In a restlessness, your symptoms are going up. So you go this way. And seizures, it look like things are going up. And a slurred speech, things are going down. Hallucination, your symptoms are going up. So this is what it will look like in a table form. And this is what the individual you may see in an individual. And I told you about the cage with somebody have a question. So this is a screening tool to be able to figure out whether the individual is an alcoholic, the very alcohol user, or they just a social user, and you'll be able to distinguish between them. Remember, before I go, I told you the benzos for the CIWA is based on the dose. All right, there's no standing order for benzo. So the higher your CIWA, the higher your amount of benzo. So somebody can get a lot of benzodiazepine. You titrate it depending on how much numbers you're getting, whether it's a mild form, moderate form, or severe form of alcohol withdrawal symptoms, so that they don't go into seizures. So the dose goes up is a key NCLEX questions they may ask you. This is the easy way to remember some of the things your board may ask you. And like I said, don't forget about the pharmacology. Don't forget about other associated symptoms that they may ask you in terms of the electrolyte abnormality and that are associated with this. Any question?